Good morning, good afternoon, good evening, depending on where you're watching us from and what time you're watching us from. It's me, Cecelia Karanja, here again, founder of Fertility Kenya. Fertility Kenya deals with, it's an NGO that deals with persons struggling with infertility. And as we talked the other time, we said that we shall be going around the country talking to the doctors that are doing IVF so that we can have like a taste of what they do, or we just have like what happens at the IVF centers. So we are so privileged today, and we are so lucky and privileged to have Dr. Shaunak Khandwalla. We are at Mediheal Fertility Center, and please help me welcome Dr. Shaunak Khandwalla. Khandwalla, karibu sana.
Thank you.
Yes.
Asante.
Yes, asante sana. Thank you for receiving us. Thank you for the warm welcome you've given us. And we are so happy to have the chance to have you.
Karibu.
Yeah, asante.
Sure.
People have been telling me we want to interview with Dr. Khandwalla. Now we are here, guys, and we have Dr. Khandwalla with us. So Dr. Khandwalla, please introduce yourself.
Sure. My name is Dr. Shaunak Khandwalla, and I am the clinical director of IVF in the Mediheal group of hospitals. So we have 3 IVF centers in the Mediheal group as of now. One is where we are at Nairobi in Parklands Mediplaza. The other one is at Eldoret in Kenya, and the third one is outside Kenya in Rwanda in Kigali. So we do IVF everywhere, and I'm principally in Nairobi, but I also travel to Eldoret, I travel to Kigali to do the procedures. So everything is done under my supervision. And we do about 1200 to 1300 IVF cycles in a year now.
Wow.
Yeah.
Mm-hmm.
With a good success rate also, which we will discuss eventually.
Yes.
So basically, we have a good success rate of 60 to 70%, and you have been a first-hand witness of that.
Yes, I've been here and I've seen that happen.
Sure.
And that's why we are here. We really want to know, like, what is the secret behind this? Yeah,
Sure.
just take us through, like, from the time we get into the gate of Mediheal and we're coming to see you, Dr.
Right. So many of our patients, they come through appointments. Many of them come just online or through the registration or walk-in. And then the registration is downstairs at the main reception. So they have to register there first. The couple has to register there under my name. And once they are registered, they come up here to my office on the second floor in my waiting room, in my reception. And there they meet one of our receptionists. And that's where they are given this form in order to fill. This is a medical history. And for the couple, that is for the woman and for the man. So they fill all their details as much as they can in the language that they understand. This is a lay language. Of course, there are certain things where, supposing the couple has already undergone IVF, then they have to fill in those records. But otherwise, they fill in their medical history, surgical history, infertility history, what operations have they done before, what medications or treatment they've done before for infertility. And then they register with us and they come here. Then my assistant doctor, she takes her own history with the names of the patients written, the couples, their email IDs, their contact numbers, everything. So once this is done, then we go further. So we know at least what they have come for. And majority of my patients, they come directly for IVF because they know this is a specialized center for IVF.
Yeah.
So they don't just come for routine infertility where, so many other things can be done before we do IVF. So, everybody has to know that IVF is not the only treatment that is done for infertile couple. There are so many other treatments that can be done. IVF is the last resort.
True.
And in some couples, it is the first resort. Because if your tubes are blocked, you can't do anything else. Right?
Yeah.
So, that's, and then once they register, their history is taken, and then they are sent for a series of tests.
Okay.
So, there are tests for wife and there are tests for the husband. So I prefer that the couple comes together because many a times the wife comes alone and says, okay, no problem, my husband is normal, he doesn't need to do tests. But that's not the case, you know. You can't clap with one hand, you need two hands to clap.
True.
So you need to do both husband and wife's tests, because you never know what will come out.
Okay.
So we have this series of tests where the ladies' hormones are done. I do the ultrasound myself, the pelvic ultrasound I do myself, and the routine testing, husband semen analysis. Sometimes we do even the tubal testing, which is called the HSG or the hysterosalpingogram, where you had a program in between on Facebook, you know.
Yes, yes.
So the HSG is a very important, you know, gold standard test for infertility, because even if the tubes are blocked, it tells us whether what is the problem with the tubes. Is the tubes just blocked, or are they having a swelling like this called hydrosalpinx? Are you able to get this swelling like this called hydrosalpinx, which can then track, the fluid can track and come inside the uterus, and then cause problems for implantation. So we need to do all these tests. The ultrasound also tells us a lot about the woman, about her fertility status, ovarian status, uterus, etc. Plus the hormones tell us a lot. And of course, the man, the only most important test is the semen analysis. For my clinic is 2,000 shillings, and that's how they, when they register, and when they come in, then
So
as I told you,
to see you, Dr. We need to pay 2,000 for consultation.
Exactly.
Okay.
And then when they come in, they will do the tests, and for the tests we have prescribed amounts on our test requisition
How
form.
much is it, Dr.
Now, if the couple is doing both husband and wife, it's roughly 50K, 50,000
Okay, for the test.
for all the hormones, the routines, serology, semen analysis, ultrasound, and HSG. All
Around
that.
about that
Yeah.
much. Okay. So once we have done the test, Dr. We've done the test. How long does the results? How long does it take for us to have the result? Do you see us the same day with the results, or what happens after we've done the test?
So now typically it's like this. As I told you, my assistant doctor will see the couple, then she'll prescribe the test for the husband and wife.
Yes.
One of the tests is the TVS or the vaginal ultrasound, which I do myself. All the other tests are done in our lab. So the lab is in the next door building, which is the PMC, where very soon I am also going to shift. My IVF center will be shifting to PMC itself. So there we do all the lab tests, semen analysis. The HSG is done in the radiology, and then they come for the ultrasound to me.
Yes.
Okay.
Yes.
Now, by the time they come to for the ultrasound to me, they would have already done the other tests. So those reports are already available.
Okay.
So when I see them for the ultrasound, I have all the other reports. And when I do the ultrasound, it's real time. So I don't have to wait for that report. It comes out instantly. Fine. So then I review them on that day. And once I know everything, then I advise them what medication to take, what not to take, in order to prepare them for the IVF.
Okay. So at that point of you looking at the report is where now you analyze what you need to do with that patient.
Exactly.
And after that, maybe for example, what are the challenges that you find when you are doing your scan? Because what I know, you're very strict on the scans. You normally say nobody should do your scans. You normally do it yourself. So why do you say that you have to do it yourself?
Yeah, it is very important for the infertility specialist to do the scans themselves. They should not depend upon a sonographer, because unlike X-ray, HSG, CT, or MRI, the scan is very operator dependent. So whatever you see at that time is what is there. And I like to I like to do my the patients or clients scans myself, because I need to know them inside out, literally. How their ovaries are, how the uterus is there a problem? So even only when I know how the ovaries are and the follicles are, then only will I be able to manage that lady better, to give her a good stimulation. Because no one lady is having this. No, the treatment is not same for everyone.
Everyone.
It is customized and designed for each one. Okay, so depending upon the findings that we have to go through. Now you talked about challenges. Now the most important thing is that the ultrasound should be clean. By clean I mean the uterus should be normal, I should be able to see good number of follicles in the ovaries, everything like that. But sometimes the ovarian reserve, that is, a number of follicles in the ovary is less. Okay, so we have a different treatment for that. Then we suddenly find that there is a hydrosalpinx. We suddenly find there are fibroids. Okay,
Inside.
so fibroids inside the uterus, or even on the walls of the uterus. On the walls of the uterus, it doesn't matter, but these fibroids which are inside can act as contraceptive devices or foreign bodies, which will prevent your implantation from occurring. So we need to get rid of them, or we need to surgically treat them before we go for the IVF.
Okay.
So that's why the ultrasound is very important.
Okay.
In order to back up my ultrasound, then, if there are fibroids or such situations, I send them for a MRI of the pelvis. So the MRI will give us a three-dimensional view how the fibroids are, where they are placed, what can be their problems, how they should be operated. So the surgeon, the laparoscopic surgeon, also gets an idea of how to do the surgery.
Okay.
Because we need a minimally invasive surgery for such women, so that her uterine architecture and her uterine shape is preserved, so that I can do a good job.
Okay. Daktari, on that note, have you ever gotten somebody at that initial stage and you saw this person, they've come for IVF, and you said, no, we cannot do IVF?
Now that depends.
Mm.
It depends on so many factors. As I told you, one of the factor was the ovarian reserve. Now, if this lady has a very little ovarian reserve, but she insists on her own eggs, then I would differ with her and advise her to go for egg donation, because she does not have a proper ovarian reserve, which will be good enough to give her implantation and therefore a good possibility of pregnancy. That is one thing. There are others who have already got premature ovarian failure, like she may be 30, 35, but her ovaries are like as if she's 55. They already stopped functioning,
Yeah.
and that will be shown in the hormones also. The uterus will be small. So all these factors are there, by which it is difficult for us to go for IVF using their own gametes. Own gametes means eggs and sperms. Gametes are eggs and sperms. Okay.
Yeah.
And very rarely, there are certain clients, certain patients with the uterus is so huge, so adenomyotic, and so many fibroids that even if you do a surgery, this will not implant. So there are certain rare conditions in which we might not be able to go for IVF, but we can do IVF using certain options.
Okay. And then
So in other words, it means that there is no couple in this world today on whom you cannot do IVF.
but let me ask you, Daktari.
Hmm.
There's a patient I had that she had two uterus. Is there anything like that?
It means there can be two things, either double uterus. So there are double uterus, two of such, and two cervix on the mouth of the uterus, and then there's one in which there's a biconvex uterus, but that does not matter. Biconvex uterus or double uterus, as long as the cavity is good, we can do
You do transfer in the both uterus.
in both the uterus, yeah, to give her a better chance. Or
Very interesting.
or we select the cavity which is better, and we transfer in that.
Okay. Let me ask you, Daktari, on that part of the uterus, because it's very sensitive. Because normally we tell people, as long as you have the uterus, we are able to do for you the IVF. I hear the people who come with very small uterus. What happens in
So if there is an absent uterus or a very neonatal or a small uterus, as you say, then there is a certain limit to which we can develop the uterus. If the uterus is a slightly smaller in size, in a menopausal woman or in a woman who has undergone ovarian failure, we can develop the uterus by giving them hormones. But in a very small uterus, you cannot achieve implantation because that uterus will not function. Okay. So then such women, if they have ovaries, because there are some cases in which ovaries are present but uterus is very small. So in such cases, we have to resort to gestational surrogacy. That's what I told you.
Yes.
There is no such couple in the world which cannot get a child through IVF.
I agree.
Somehow or the other, you can always give.
Okay. So Dr. we've come and we've confirmed that everything is okay. My uterus is fine. My only problem is the tube and maybe the ovaries or something. So what happens after that? After you've seen what do we do? Where do we proceed from the scan?
Right. So now the thing is, we have to determine the, as you were saying, through our investigations, that is the tests, through the ultrasound, etc., we have determined what is the factor for infertility. Or she may have already come with that. I mean, many women come to me at a stage when they have already been diagnosed with with ovarian failure or tubal blockage. So that is we have assigned that factor. So this is a female factor or a male factor. So there are so many factors in infertility, as you know, ladies side and the man side, and then both side also. And then there is something called unexplained, where there is nothing wrong. Okay, there's nothing wrong, but they are not able to conceive.
Yes.
Okay, so there is, it is called unexplained infertility. So 30 to 35% of the time the woman is enrolled, 30% of the time the man is enrolled. So that's 65. About 25% of the time both are involved, and the remaining is unexplained. Where
What's the difference between the IVF and ICSI?
so can I do a pictorial demonstration?
Yes.
So this is how it looks. Now, just to give you a brief idea, are you getting? Because okay. Tell me if you are seeing. Okay, what we do is in a typical IVF cycle, this is what we do. We sorry, we do the ovarian stimulation. So we do the ovarian stimulation by giving injections from the second day of the menses. So this ovary, which is so small, will become having so many follicles. We like to develop 8 to 10 or even more follicles. Some women, they develop 15, 20, 25. Okay. So we give this injections right up to the time when they are mature. Then we trigger them, and then we remove the eggs by a certain procedure, which is under anesthesia, but there is no incision, no cuts on the abdomen. It is done through the vagina. So you go inside, see the ovaries, and you puncture the ovaries and remove the eggs from the follicles.
Yeah.
So once that is done, then you have the eggs. The husband gives the sperms on the same day by ejaculate sample. The sperms are processed, and in IVF, that is in vitro fertilization, what we used to do conventionally, you put a single egg in the petri dish and put a drop of sperm which contains 100,000 sperms, from which one of them will find its way and fertilize the egg. One. Sometimes two may happen, but very rarely one happens. So when you fertilize, then after 3 days they form the embryos. Okay.
Yes.
Now what do we do in ICSI? ICSI means in vitro. ICSI is intracytoplasmic. You see, this is the cytoplasm of the egg.
Yes.
So this is the whole egg. We have held the egg with the pipette. Then we hold it and we take a sperm, single sperm. A single sperm is injected into a single egg.
Okay.
That is called intra. Intra means inside. Cytoplasm means in the cytoplasm. Sperm injection, ICSI, or ICSI as we fondly call it.
Okay.
Okay. So the same thing happens after fertilization. 3 days later, we have embryos. Okay, so these are the two ways of fertilization, and then of course we do the embryo transfer once the embryos are developed.
On that note, Daktari, what is better? Is it ICSI or IVF?
So that's a big debate.
Yes.
Sawa.
Yes.
Now many people who have got ICSI equipment like what we have and so many others also have. ICSI, by the way, the history of ICSI I'll tell you. Very interesting.
Yes.
What happened was that earlier they used to do what is called as, we IVF people are very fond of acronyms. Acronyms means IVF, ICSI, ICSI. So there was something called SUZI, SUZI.
SUZI.
Okay. So what they tried to do was, this egg is there. This is the zona. It's called the zona, the wall of the egg. So they tried to put the sperm here, subzonal implant. SUZI, SUZI. So when they tried to do that, they thought it will improve the implantation better than the IVF. But by mistake, that guy punctured the cytoplasm and the sperm went inside. And it fertilized and it gave a pregnancy. So they said, oh, look, we'll do this. Why not put it in the cytoplasm? And that's how ICSI started. in early 90s, 1990, the last century.
Okay.
So it's been more than 30 years now. Okay, we've been doing ICSI since a long time, and 100% of the cases, almost 100% of the cases, we are doing ICSI or ICSI because ICSI, as you saw in the procedure which I demonstrated, the sperm are put right inside the egg. The sperm doesn't have to do anything. Whereas in IVF, the sperm has to do its own work to penetrate the egg and fertilize it. So, in which case, it's more difficult for the sperm sometimes, and therefore, it is easier to do an ICSI to ensure better fertilization and therefore better success rate. But there are so many people who will argue with me and say, in all cases, ICSI is not really necessary. 70 or to 80% we do ICSI, 20%. I mean, that's what happens in the developed world. 70 to 80% they do ICSI, 20% they still continue doing conventional IVF. Because see, if you have a donor sperm, or if you have a very good sperm from a man, the husband, and the wife is youngish, but the only problem is her tubal factor, her tubes are blocked. But otherwise everything is fine with her. You can do IVF and get very good.
That's why I'm here and I'm wondering. You've put the eggs in a dish, eh? All of them, maybe
one egg. Just one egg.
It's just one egg.
Just one egg on which you put the drop of 50, 100,000 sperms.
So if it is 10, it's 10, whatever.
Yeah.
10.
So one egg has to be put in one dish. Yeah. But we have different dishes. We have those square dishes where there are 4 wells. So in each well you put an egg and then you drop a sperm.
Oh. So
that sperm contains 100,000, that drop contains 100,000 sperms, spermatozoa.
So I'm here wondering, you've put there 100,000 sperm. How do you know that egg, by the time, how long does it take for you to remove it, and how do you know that it has fertilized?
So there are ways of doing it. The embryologists know better than me. After 4 hours of doing this fertilization, they check.
Oh.
And they know there are certain developments in the egg. The cleavage has started. Okay. So they remove the egg and they put it in a different medium. And then after 16 hours, they remove the shell of the egg. And that time when they remove the cover of the egg, they'll know the 2PN or the 2 pronuclei stage. That means the pregnancy, the fertilization is already on the way.
Okay. Now, Dr. tell us.
And we have achieved pregnancy through conventional IVF also. So it's not necessary to do ICSI for everybody. But most of the patients who come to me have already had IVF before, they have failed, or they have got endometriosis or a severe low male sperm count. So many other factors which necessitate me to do ICSI.
Okay, Dr. Now you have said once you fertilize the egg, you put it to up to day 3, then you transfer.
Right.
What are the other things that we need to know just before you transfer? What are the other advantages?
So, we have so many options.
Yeah.
Like in many of my patients, I do what is called as all freeze protocol. All freeze protocol means I do not transfer in that cycle. Because when I stimulate the woman, there are changes in the endometrium also.
Yeah.
Because ovaries, uterus, they are all interrelated and the hormones act on everything. So when you stimulate the ovaries and when the eggs are produced, they also act on the lining of the uterus, and therefore the lining may not be good enough to implant in that cycle. So what we do, we freeze them. So we have a very good freezing chamber unit where it's a very successful freezing unit in which of course you'll be able to see it downstairs when you go there.
Yeah.
My embryologist will show them to you. But if you do not want to freeze, there are other options also.
Yeah.
If you do not want to transfer, we freeze them, and when you thaw them, they are as good as new. So you don't lose out anything in the freezing. The embryos remain the same. But as you were asking me, what is the option for day 3? We have a day 5 transfer, or what is called as blastocyst.
Yes.
So let me tell you what happens in nature. Okay, in nature, when a woman conceives, this is what happens with her. Her eggs, they come out on the 14th day. The ovulation takes place on the 14th day.
Sure.
Right? Of a 28-day cycle. That means in the mid-cycle. What happens to the egg? It's picked up by the fallopian tube. The fallopian tube is close to the ovary. So it has got finger-like projections.
Yes.
See, like these. So it picks up the egg and then it transports the egg inside.
Yes.
Now, when the lady has sex, the sperms travel like this.
Yes.
This is through her vagina, cervix, uterus. Some sperms also find their way to this egg.
Yes.
So that egg is fertilized by the sperm,
Yes.
one sperm. And then it starts, the fertilized egg starts its journey. So this journey from this place to the uterus till it implants, it takes 5 days. So it is a blastocyst that implants in nature, not the embryo. In IVF, we started doing at the embryo stage because that time we did not have good incubators and culture conditions initially. I'm talking about the 1990s. We did not have good culture conditions to take them to day 5. Okay. But now that we have the latest incubators, latest culture conditions, and the latest talent, we can take them to blastocyst stage or day 5, so that when you come close to nature, or when you simulate nature, you get the best results. Okay, I just wanted to show you. There you go. So this is a blastocyst. The blastocyst develops like this, and then you have to wait for 5 days for this to happen. And on the 5th day, you see this picture,
Yes.
like a good blastocyst, and then you put it in before it hatches fully. See, this is, you see that's coming out.
Yes.
There's the hatching part.
Yes.
Okay, so when it just starts hatching, we transfer the blastocyst in the uterus and gives very good implantation rate, almost 70 to 80%. So this is what we do. And then for frozen embryos, if we have to transfer them on day 3, we have what is called as laser assisted hatching. So instead of it hatching on its own, we facilitate the hatching by putting the laser.
So what do you do? What do you mean by putting the laser?
By our embryologist, under the microscope, under vision, it's just like playing a video game where you shoot a particular target.
Okay.
So they bring that embryo wall below the laser crosshair, and then they make few punctures.
So what
So
you
the
trying?
wall of the embryo becomes thinned out.
Oh.
So it helps when it goes inside to
just hatch.
Yeah.
Okay.
Hmm.
So there are 3 things you can do. Day 3, you can do laser
Day 5.
hatching, or day 5.
Yeah.
You can do the 3 things.
Hmm.
Great. And is the price? What is the price of IVF, and what is the if I'm to choose day 5? How much am I supposed to pay? Is it extra or is the same thing?
So for a patient who is paying cash for the ICSI package or the IVF package, it is 450,000.
Okay.
At
For the
Mediheal.
IVF.
Yeah, for the IVF.
450. And the 450.
That is the package which includes the ovarian stimulation, the egg retrieval, the fertilization after processing the sperms using the ICSI technique, and embryo transfer on day 3. It does not include medicines, the add-ons like what we talked, day 5, laser hatching, freezing, etc. We can freeze the embryos even after doing the transfer. If we have extra embryos, we can freeze them for the future for that couple. So they don't have to go through everything again. They don't have to pay 450,000. They can pay only 110,000 and do a frozen embryo transfer.
Oh, they can do the frozen.
After they have paid the annual fees for freezing. The annual fees for freezing are like 40,000.
Okay.
And blastocyst is 50,000.
50,000
Yeah.
for the day 5. When you say blastocyst, we know it's
day
day
5.
5.
Exactly.
Okay. So, Daktari, we have done the transfer. We've gone to downstairs. No, we have not removed. We've removed the eggs. At what point do you transfer us? Maybe we didn't go through. Once we have our period and you've prepared us, now we are doing the IVF procedure. So take us just back a little bit. Once you have confirmed that we are okay, what point do we come to do the procedure? You give us medication, or we just come the second day of our period? What other preparation do you do to us before we come and do the IVF procedure?
Right. So what we do is we program the cycles, and we give a program to the woman, to the couple.
Yeah.
Depending upon what treatment they are undergoing. So basically, if you just broadly divide these treatments, one is when we are doing ICSI using their own gametes. That means her own eggs and her husband's or partner's sperms. The second is that when we are doing third party treatment, that is egg donation, sperm donation, embryo donation. And the third part is the frozen embryo transfer. Okay, so we have different programs for different women. We program them in such a way by giving them oral contraceptives,
Okay.
so that they bleed at a certain day.
Mm-hmm.
So when they bleed at that time, they come on the second or third day of their menses to me for starting the process of ovarian stimulation.
Okay.
They have already been on medication to boost their ovaries, to boost their sperms. So many other supplements have already been given.
Yes. Terry, there's a part that we left. That part of after you've done the scan, what do you do? What other preparation do you do before now they come on the second day of their period? Or do you just tell them once you've done the scan, go home and come the second day of the period, or what do you do?
So now that I have seen the couple,
Mm-hmm.
I have seen all the test reports, I have done the ladies' ultrasound. Of course, sometimes I do the man's ultrasound also. We need to do testicular ultrasound for the man. That I forgot to tell you.
Yes.
If he has a very, very, very low sperm count, or if he's got azoospermia, that means zero sperm count. Okay, so I've done the scans, we've seen the reports, we've reviewed them. Then I identify the actual cause, and then we start them on medications. It's very important to prepare them, even if it takes 2 or 3 months, using supplements. For example, for the lady, if she's got a low ovarian reserve, I'll give her DHEA to boost her ovaries. For the man, I'll give him supplements to boost his sperms if he's got a borderline low count. So that is very important. It's not just that you need to do IVF. Okay, anybody can do IVF, but the more important thing is the bottom line. And what is the bottom line? What the couple has come here for, and that is a live birth. So, in order to give a live birth, we need to prepare. As they say in a war, full preparation is half the battle won. So, if you prepare them well, you'll get good eggs, good sperms, and therefore good results.
Yes.
Right? So, sometimes it may take 2 or 3 months. As you know, the sperm cycle and an egg cycle is 3 months. 90 days it takes for the full sperms to form properly. So, you need to therefore give for 90 days, whether you give it for the sperm or you give it to the woman for the eggs. Only then do I program them or plan them to come in for the IVF. And the IVF cycle is programmed here. We do it in groups or cohorts of patients, and we program them using oral contraceptives. So their periods or menses are programmed with oral contraceptives. They fall within a week or 10 days. All of them come with their menses on the second or third day, and that's when I start the actual treatment. And as I told you, the treatment depends upon the type of treatment we are doing. So if I am going to stimulate the ovaries, we'll give the injections from the second day
Of the period.
of the menses, when she gets the bleeding on the second or third day. After we see, even on the second or third day when she comes to me, I have to do a scan for her, because things could have changed since what I last saw her. So I have to do a scan and see whether everything is fine inside. Only then I start them on the injections. These ovarian stimulation injections are for a period of 10 to 12 days approximately. So after 10 to 12 days, they'll be ready for egg retrieval. And we do egg retrieval in our IVF OT under proper precautions, under anesthesia. It's just about a half an hour to 45-minute job. It's a daycare procedure. So they are in the recovery room for another half an hour, and then they can go home.
Okay, so Dr. when they come after you have prepared them, you prepare them to now come after maybe two months. They come when the second day of their period. When they come here on the second or the third day of their period, what happens?
So that's what I'm saying. We have already given them the full printed program and explained to them what has to be done. Then they come here on that's the starting point. The starting point is the second or third day of their bleeding or the menses, of the periods. When they come here, as I told you, if we are going to start ovarian stimulation, I have done the scan for them on that day, and we give them injections.
So you first do the scan.
We do the scan, see whether everything is okay. If things are okay, I may need to do some fine tuning at that time. I may have decided earlier that I want to give her a particular dose of injections. But on the scan, I may think differently. So then I instruct my nurses to give them injections. I put it down on the paper, and they come every day. The injections are daily.
Okay.
Even on Sundays, my nurses come here to give the injections.
Oh, even on Sundays.
Yeah, and I prefer the patients coming here to take the injections. Though in very rare circumstances, we give it to them if the lady herself is a nurse, or she knows, or she has some place to inject, or she's coming from far.
Okay. Doctor, in the injections, I thought they are the same. They are not normally the same.
Yeah, they are the same for everyone, but the doses vary.
The doses are they vary depending now on what you have seen.
Exactly.
Okay. So
And the protocols vary. Some people may need this injection plus oral medicine. Some people need only injection. Some people need a combination of two injections. So there are so many things.
Okay. That determine.
Yeah, so I cannot discuss all those things, because that means, then we'll have to go into the ovarian physiology, and hypothalamo pituitary axis and all that. So we cannot discuss all that.
Yeah.
But more or less the injection brands and everything are the same. The molecules are the same. Doses are different, and the structuring is different for different patients.
Okay. Doctor, I normally see you're very thorough on the uterus, the size, the thickness, and all this. What is that you normally check? What is the right thickness for a transfer?
So what we do is, when we are doing this ovarian stimulation, okay, we are checking on the follicles in the ovaries. Okay.
Yes.
But along with that, the uterine lining is also developing. As you know, in a normal cycle, when the woman is producing an egg and it's growing, the lining also starts growing. So at the time of ovulation, the lining is best. Now, what is the best lining? So the endometrial thickness we can determine or measure on ultrasound, and that is anywhere between 7 to 12 millimeter. So we measure that. And the echo pattern of the lining, the way the lining is, that is also important. Plus, I do blood flow studies. I do blood flow studies to know how much is the blood going to the lining.
Through the scan?
Through the scan.
Okay.
We do what is called as Doppler study. We can see in color the blood flowing to the this.
That's good.
So that will tell us how good or not this lining is.
The lining is.
Especially for women who are not undergoing ovarian stimulation. Even they come on the second or third day to start the process. Yes. I'm talking about those who are having a frozen embryo transfer, or who are receiving embryos donated to them or eggs donated to them. So even they come on the second or third day, and even they take about 7 to 10 days for the lining to grow.
Yes.
Once the lining grows, then we plan the embryo transfer.
Okay.
And once the egg retrieval is done, then we call them again after 3 days. After 3 days, as you know, the eggs have been fertilized and they're ready for embryos. Then we review the embryos, and then we of course advise them freezing, day 5, blastocyst, other things.
Okay, I've seen so many people
So it means that from the starting, that is from the second day or third day, in 3 weeks we are done.
In 3 weeks we are done. So I've seen in rare cases, but I've seen you cancel somebody's procedure because of the thickness of the lining. Can that is that a cause for you to cancel a procedure?
Yeah, because if the lining is very thin, like 5 or 6 millimeter, and it's not reached a particular thickness, then implantation is not going to take place. At the same time, when the lining is thicker, like 13, 14 millimeter, I still cancel. Also, women who go into ovarian hyperstimulation, those who have been given injections, but they respond, there are some very high responders like polycystic ovarian disease people,
Yes.
who have PCOS. They respond with too many follicles, like 20 plus. In that case, we do not do the embryo transfer. We freeze all the embryos.
You freeze the embryos. You will remove the embryos, but you will not transfer.
We'll remove the eggs, fertilize them, and put them into the fridge or the freezer.
Okay.
But there are certain ladies who are going for embryo donation, egg donation. They don't grow their lining properly because there is some inherent problem. So what we do is we try to increase the dose and try to push the lining. But if it doesn't grow, then we have to resort to something else.
What is the worst scenario you've had where you've taken a patient for the transfer and you did not transfer, like on the transfer bed? you went there and you were ready to transfer and you could not transfer. Have you ever been in
Yeah,
such
so
a
there have been
situation?
several instances like
Mhm.
that. Of course, every batch of 100 or so, we would have one or two patients like that. So 1% or 2% of embryo transfers can be very difficult. One, they can be difficult because the woman's passage may not be good enough to go in. You know, even though you may have tested it before, the cervix
That's
may
the
be
vagina
the
or the cervix.
cervix.
Okay.
Yeah, the cervix.
Mhm.
So the cervix may be quite close at that time,
Mhm.
and it may not allow. And embryo transfer is the most important part of the whole IVF,
True.
because if you do not do the transfer of the embryo properly, whatever you have done before that comes to nothing.
Nothing. True.
So it is a very delicate procedure also, and it has to be done very nicely without any bleeding, without any problems. Because if there is any bleeding or problems, the uterus will start throwing the embryo out.
Imagine.
So we need to do it so well and so nicely that it should go very smooth. Now, if there's a problem about that catheter going inside, and then there are various ways to do it. Then we hold it, we try to open the passage with the dilator, but that causes trauma
True.
and bleeding.
Mm.
And many people still go ahead with the transfer, but I don't.
Yeah, you don't.
So even if I get through the passage, I will not put many people will be tempted to put the catheter and put the embryos. But see, again, I'm coming back to the same thing. We are not doing IVF just for the sake of doing IVF. We are doing IVF to get a pregnancy. So how can I just put? The lady will be very disappointed on the table.
True.
She will be wondering why I did this.
Yes.
But then we have to explain to her and counsel her that I am wasting her cycle. So rather than wasting her embryos, it's better that she comes, we freeze them. And now since we have got freezing technique, earlier there was no freezing way back. So then they had to put the embryos back. But now that we are freezing, we can do anytime we want. And in between, we can prepare her in such a way that she does not have a problem like this. So such ladies, what we do is we take them under anesthesia, the transfer. Sometimes I go on the table and she may have just bled and her lining becomes thin. Then I have to cancel.
You have to cancel.
So these are the various things which will make me cancel and disappoint the patient.
True.
But it's for her own good that I'm doing.
Yeah. There's no
And then there are some patients who have done ovarian stimulation and they don't have so many eggs at that time, or they don't go into hyperstimulation. But on the table, I find, the ovaries are quite big. So then I counsel them. I may cancel, or I may just put 1 or 2 day 5. So she doesn't go into more hyperstimulation.
Okay. So thank you, Dr. After you've done the transfer, I want us now to go to the part that you've done the transfer. You give out medication, or what do you do? Do you tell the patient to just go without medication, or what normally happens after the transfer?
So once we have done the embryo transfer, there are a host of medicines which are starting just before and which are continuing for at least 2 weeks.
Okay.
And that is called, in our clinical term, luteal phase support. Luteal phase support means the pregnancy that is going to implant, we need to support that pregnancy. So it's a luteal phase support. Mainly it has got progesterone, some steroids, aspirin, other things. Sorry. And then this is essentially for 2 weeks.
Yes.
So after 2 weeks, we call her to do a very important test, which is beta HCG. So blood beta HCG test will tell us whether she is pregnant.
Okay.
Once she is pregnant, we continue the same medication and then call her again after 2 weeks for scan. If she is not pregnant, unfortunately, then we have to sort out things and try another time.
Okay.
So this is basically the whole treatment. So it's 3 weeks of active treatment, 2 weeks of rest with medication. After 5 weeks, we know the blood test.
Okay. So once we confirm the patient did not succeed, what happens?
So if her beta HCG is negative,
yes,
and it's too early to do anything on that, tell her anything on that day, because she's very disappointed.
Yeah.
The couple is very disappointed, so they may not be conducive to any other options. Because I would like them to come again to me. We would like to try something some other way. If they have frozen embryos, we would like to use the frozen embryo. There are so many things that you can do. There are so many times that I have counseled the patient, even a not very old woman, but let's say in her mid-30s, she has not conceived, I would like her to try with donor eggs. Try something different. Because there are so many factors involved in IVF. So we need to change the things, every time. But on that time, it's too early to tell them. So we just tell them to stop the medication.
Yes.
And then they think about it, and then they can come later on,
come back,
at which time we can advise them as to what next to do.
What's next?
But when they are pregnant, then they are so happy.
Very.
So that, we just tell them to continue, and we call them for a scan after 2 weeks. The scan will tell us how many pregnancies are there and how is it growing.
Okay. So,
There you go.
Okay. So, Dr. Ray, now I want you to tell me briefly, like from consultation is 2,000, the procedure is this much, the medication before and after. Just a brief of like the breakdown of how it is. Just brief on the amount of money they need to spend.
We start with consultation.
Yes.
Consultation is 2,000.
Yes.
Then the tests for both husband and wife are around 50,000.
Yes.
Then you come to the IVF procedure, there is 450,000.
Yes.
The medications which are used to prepare before can be anywhere between 25 to 30,000.
True.
But the medication given during and after the procedure are around 50,000. 50,000. That is during and the 2 weeks after.
And the 2 weeks after.
Yeah,
okay.
Approximately.
So the medication before and after the transfer is around 50,000.
No. Before means the 2 months that we take to prepare is different. Okay. The medication which is given before and after means immediately before the transfer and immediately after the transfer, till the 2 weeks after the transfer is 50,000. So the ones that we start, like we start Proganova to grow the lining.
Yes.
Then we give Dufaston, Progesterone and all that after the transfer. All that I'm talking about is on an average 50,000.
Yes.
So we talk about 450 plus 50, it's 500. And the medication that they spend before maybe 25, 30,000 plus the test is 50,000, so 80. So about 600,000.
Okay. And also, Dr. Ray, how much is freezing and how much is egg donation? People would want to just know how much they
So egg donation is 100,000 extra for donor egg.
Yes.
Just eggs.
Just eggs.
If it's embryo donation, that means donor eggs and donor sperm. It is 100,000 for donor egg, 25,000 for donor sperm.
Donor sperm. Okay.
Day 5 or blastocyst transfer is 50,000. 40,000 is per year freezing charge.
Okay.
Per year.
Per year freezing charges. That is very good. At least we've known how much it will cost us to just do the whole procedure. And also, people should check out on your offers. You should tell them that you normally give them offers.
So we advertise them quite frequently in Facebook.
So once in a while, you normally give us offers.
Once in a while means, I think on an average twice in a year.
Twice in a year. Okay. So thank you, Dr. Ray. Also, sure. I've known you for quite some time. I've worked with you for quite some time, and I know your passion. I know, and that is why I'm normally I see people agitated that you have cancelled their procedure, and you're there saying it is for your good. I did this because of your good. I really don't know what is this that drives you. Why are you so passionate about whatever?
When I was a student, I used to study. When I was a med student, I used to I used to give my 100% to that thing. I would never shirk from that. And as far as work is also concerned, my wife also complains that I'm a workaholic. I don't give enough time to, I'm staying alone here.
Yeah.
My family is not with me. So, so they complain that I'm always talking about work and this and all that. So actually, when I came to Nairobi or Kenya, and when I'm controlling the whole thing here now, as I'm as a clinical director, I find it so satisfying professionally to see the journey of that couple from the beginning to the end. And that is what makes me, and the success story behind so many couples that have gone through Mediheal makes me still more passionate about my own profession or what I do. And I've always been like that in my life, passionate about everything, what I do.
Yeah, I've seen.
That's why some people say that you are very emotional about your work. You think too much about it, but I'm like that. I can't change that.
And that is why it's working out so well, and that is
God,
why we have very good
God bless us.
results for this. I am always shocked when you come and ask Daktari of a patient who did, and is there saying, yes, Cecelia Karanja who did it in 2018 and he got twins. So I'm just like, I mean, it's the passion behind it.
Sure.
I just love it.
Thanks.
It's good that you're able to just give out to the community, and there are many of the times I've come here, cried to you and told you that this couple has a problem, and you've listened to them, and you've also helped them, as in you've even reduced the prices. The only thing we can say is that may God continue to bless you. So many people, they're out there, they call me, hey, I got a baby for Khandwalla. I have a Khandwalla. They say we have Khandwalla baby.
Yeah, so it is so professionally satisfying when they send on WhatsApp groups the photograph of the baby. Like recently somebody sent me twins photographs. So it's so nice to know that. And that you have done, you have played a role or played a part in that happening,
Yeah.
Very satisfying.
Yeah, so thank you so much for continuing to do that. Whatever you're doing with the passion, just continue doing the same. Just know we appreciate you, even when we don't tell you. Just know that we really appreciate you. Me, I have thousands and thousands of women who come back to me and tell me, please tell Khandwalla. I'm so grateful that he did this to us. He saved my marriage.
Actually, God has done it. Yeah. I have just been an instrument.
Yeah. And you agreed to be used by God. Because if you did not agree to be used of God, you'll not be here doing that. So thank you very much, Daktari. And may God continue to bless you. May He give you long life so that we can see you and continue to see Khandwalla's baby. So, parting shot, maybe you can tell us something, Daktari.
Yeah, so, okay, so I think what is more important for everybody to know is that IVF is not an easy thing. I agree that all the couples, they invest a lot, not only financially, but also physically, emotionally, and they are drained, in the whole treatment. But you have to understand there are so many factors involved in IVF, and therefore the success rate it's not like doing any other surgery where you do a hysterectomy and the uterus is out and the problem is over. You do a C-section and the baby is delivered. You do a myomectomy, fibroids are out. But it's not as easy as that. There are so many things involved, and still we are still struggling, but still we are giving good success rate. 60 to 70% is world standard.
True.
Beyond that, God only can help.
True.
As I tell all my patients, and I believe in this also, there are two factors very important in IVF. One is the number and one is your luck. The number means the number of embryos you have or the eggs you get. The higher the number, the better will be your success rate, because we can do so many things with that. And the luck that you bring and the luck that we bring for you. There you go.
Wow. Thank you so much, Dr. Okay. God bless you. Thanks. So thank you so much, my viewers, and we are so grateful to be at Mediheal Fertility Center with Dr. Shaunak Khandwalla. And if you have any questions, you're free to reach Dr. Khandwalla. How do they reach you, Dr. Rick?
So we can give them the contact.
Yes, you can.
Details.
Oh yeah, you can.
My number.
Yes, you can give them.
Okay, so you can. Should I say that?
Yeah.
So it's 0789 26 7896. It's on WhatsApp.
And Facebook page, your Facebook page?
Or you can, you can go to my Facebook also, Shaunak Khandwalla.
Okay. So if you have any question that you'd want to ask Dr. Khandwalla.
And there is a Mediheal group Facebook page also.
Okay. They can reach you also there. Okay. Which one is it? Maybe
it's called Mediheal. But it's better that they come to my page.
Okay, to your
Shaunak
page.
Khandwalla.
Okay. So if you have any question you want to, or anything you want to ask Dr. Shaunak Khandwalla, you could reach him on the number that is given you. And if you want to also you can also go to his Facebook page, Shaunak Khandwalla, and you will be able to reach him and he'll answer all the questions that you'll be having. Till next time, may God bless you and may you keep safe.